All right, so we're going to go a little more detail in inflammation and tissue repair. Not too much detail in a sense that I know that you are going to get inflammation and tissue healing in your patho course. So when we talk about inflammation, normal inflammation can last somewhere about 2 weeks in length, give or take. I had said I don't like the idea of putting specific numbers and days with this process. You really need to rely on the signs and symptoms associated with the inflammatory phase. So inflammation, proliferation, and maturation are our primary phases of healing. Inflammation greater than 4 weeks becomes kind of subacute. And then when does it become chronic? Chronic inflammation can last months and years. Is it 2 months that it becomes chronic? Is it 3 months? Again, the concern is not necessarily labeling chronic inflammation, but you're looking at the increase in collagen production, the increase in the laying down of scar tissue, and the increased opportunity for adhesions to form. The initial response of the body is vasoconstriction following an injury. The vessels close down tightly. There are chemical mediators that then cause vasodilation. Our goal is clot formation, and then macrophages come in and clean up and debride the tissue. The progression to the proliferation phase is the closure of the wound or epithelialization. We see collagen production. The wound closes tight, and then angiogenesis and new vascularization is being formed. During the maturation phase, we get a continued breakdown and buildup of collagen. Fibers of the collagen best orient to the original tissue, and then we have a healed injury, so we would like to say. We talk about healing by primary intention or primary union, or healing by secondary intention or secondary union. Primary intention is a surgically closed wound or wound closed by sutures, and healing by secondary intention is letting the body heal and close that wound itself. The major difference is that epithelialization. We manually close the wound with sutures, less time for that wound to heal. Inflammation, clinical signs. We say pain before tissue resistance. So if we're looking at range of motion, and a normal joint range of motion is 0 to 50 degrees. And before we get to that 50 degrees, as a clinician, we do not feel tissue limitation, and the patient stops us due to pain. That's inflammation. Other signs: heat, redness, swelling, increased pain, loss of function. Those are your cardinal signs of inflammation. Your textbook likes to say that inflammation phase is 1 to 6 days. Again, you have to rely on those signs and symptoms of the inflammatory phase. Okay. Our treatment, we like to protect that healing tissue, control inflammation, decrease pain, modify pain. We may do passive motion, massage. We might do muscle setting activities or isometric contractions to limit joint motion. Right? So we want to protect this tissue and allow it to heal. During this subacute stage, where we start to progress to proliferation, we see a removal of the noxious stimulus. We see a growth of capillary beds or granular tissue, nice healthy granular tissue. We get collagen formation, but understand that that early transition to this proliferation phase, the tissue is still very easily injured. It's fragile, it's very weak. Clinical signs. So we say there's a decrease in the signs of inflammation: decreased redness, decreased pain, decreased tissue temperature, right? We say in passive range of motion, we say pain equal to tissue resistance. So if we go back to this fictitious joint that we say is 0 to 50 degrees of range of motion, and during passive range of motion we get to about 45 degrees and we start to feel tissue resistance, and it is due to that tissue resistance that the patient feels pain. We have now moved beyond the inflammatory phase, and they are in the proliferation phase of healing. This is our controlled motion phase. We do move the joint, but we control that motion because we want to promote healing and we want a nice mobile scar. We're talking about non-destructive active resistance. We don't want to put stress or stretch across the tissue such that it injures that tissue. We do open chain, closed chain activities, muscular endurance, and we carefully progress intensity and range. Proliferation, your textbook likes to say somewhere about 20 days, give or take. I often search through the new editions in your textbooks to see if we can find a change in those dates or those days. So your textbook says anywhere from day 3 to day 20 is that proliferation phase. It's the closing of the wound, it's the laying down of scar tissue. That is the proliferation phase. Understand that as the scar matures, it is pressure sensitive, right? Sometimes there's a redness in the scar. It's just reestablishing the blood flow within that scar tissue. We want that scar to heal strong, but we also want to modify it such that we don't get an overformation of that scar. We don't want it to lead to restrictions. We don't want to lead to a contracture. Neurovascularization in the proliferation phase, it's essentially development of a new blood supply to the injured area. The injured tissue necrosis, gets debrided, cleaned up, and we get a new formation of those capillary beds. Angiogenesis is the regrowth of these new blood vessels. Again, with these new blood vessels, we get a fresh supply of oxygen-rich blood to the tissue. The healing tissue cannot progress without oxygen present. So angiogenesis is very important in this healing process. The chronic stage or maturation remodeling, in this point we mean chronic is something good. So maturation phase here, we get mature connective tissue. The scar tissue breaks down, better aligns with the underlying tissue, and the collagen can respond and align to stress. There's no inflammation, no redness, no pain, and pain after tissue resistance. So again, we return to this joint that has 0 to 50 degrees of motion, and we say at 50 degrees you feel tissue resistance. We stretch, and then our patient may report discomfort. We are in the maturation phase. It's our return to function phase, increased strength, improved scar alignment, functional independence, strengthening, stretching, endurance, functional activities, specificity drills, all in that maturation phase. Maturation phase is really the longest phase of tissue healing. Understand that during the maturation phase, the collagen, which is primarily synthesized and deposited, is type 1. The rate of maturation and final physical characteristics are determined by the orientation of these fibers. Right? We get a buildup and breakdown of these fibers. It is oxygen dependent for the depositing of scar tissue. Um, the rate of production is greater than the rate of breakdown. We get a keloid or a hypertrophic scar, meaning that a keloid will extend beyond the normal scar boundaries of the injury and invade the surrounding tissue. A hypertrophic scar is one that is red, raised, um, and but still remains within its original boundaries. So we're looking at the transition of collagen of type 1 and type 3, and we are also looking at avoiding chronic inflammation. This is just a chart taking from your textbook saying that the most abundant type of collagen is type 1, blood vessels and so forth are type 3, and we get that transition of scar tissue laid down actually as type 3 during healing tissue and makes its eventual transition to type 1. So this breakdown and buildup of or laying down of collagen could last upwards of a year to 2 years. As long as the scar remains more red than the surrounding tissue, then you know that this process is still occurring. We also have to keep in mind the tension theory, meaning that tension across healing tissue could be very good or tension across healing tissue could be very bad. Too much stress, too much tension is going to tear tissue and keep it from progressing through its stages. But understand that scar tissue needs low load, long duration stretch at the appropriate phase for permanent changes to occur. Internal and external stress placed upon this tissue while it is remodeling will determine the type of tissue. So low load, long duration, our tissue heals stronger and more like the original tissue. Tissue healing could have one of four outcomes. In a perfect world, we have complete recovery, right? We have healing by scar formation in hopes that our treatment limits how much the scar will inhibit motion and activity. We could get an abscess, which is not a great thing, or it could progress to chronic inflammation, which is also not a great thing. Understand that factors that affect healing, the presence of infection will prolong healing, edema present could lay down excess scar tissue, cause adhesions, excessive stress could keep driving this healing tissue back to the inflammatory process, cause edema and excessive scar tissue. And then the vascular supply, a lack of vascular supply certainly could affect tissue healing. So local and systemic factors, the type of injury that occurs, the size of the wound or size of tissue injury, where it is located. We mentioned if an infection is present. In bone healing, we're concerned about the vascular supply. We know that the talus has a poor vascular supply, so talus fracture certainly could be impeded by the lack of blood supply to the area. Excessive forces could impede healing. The age of our patient, very young versus very old. Very young heal much more quickly than very old. If there are other comorbidities, that could delay the healing process. Patient's nutrition could certainly impede the healing process. Movement, when there shouldn't be movement to the joint, could impede the healing process. So we also talk about the stages of fracture healing. We have an impaction, we have an induction, there's an inflammation, a soft callus, a hard callus, and remodeling. I'm just going to briefly define what those are during this healing process. So impaction is essentially the insult that causes the fracture. The energy has to go somewhere, gets dissipated across the bone, and we get a fracture. Induction is immediately after impaction. We get the osteogenic capabilities. The bone, the osteoclast, osteoblasts get activated right after impaction. That's induction, when these cells start to become active for the healing of a fracture. Inflammation runs from the moment of impaction to when we start to get a fibrous union at the fracture site. The soft callus, we get a decrease in pain and swelling, and then when the bony fragments are united, we start to see that on x-ray a little bit. Sometimes they appear as a cloudy area around the healing bone, and that's our soft callus. The hard callus, we see bright white, kind of a sticky hard callus on x-ray, covers the ends of the fracture. The new bone unites. We say it's the beginning of clinical and radiological healing, because you can really see that healing process on x-ray. Remodeling begins when we have clinical healing and radiological healing. So clinically, time-wise, tissue is healed, is stable, there's no pain, and the x-ray confirms that there's no, or that the fracture has healed. Recommendations for success. Please take some time to read the first 3 chapters. The one thing that I like most about this Cameron text is it's an easy read. There's a lot of great information, a lot of great information in this textbook, but it's a very smooth read. You're going to find that these lectures follow the textbook very, very closely. The first 3 chapters give you 45 pages of information. So please read the chapters. You will have quizzes as you go forward. Please take those quizzes and email me questions as needed.